said before, yes, 2007 is a long time to wait for some elderly people. However, they will see immediate results this year. The rates are going down this year by $1,275 a day, $4,600 a year. They will go down further the next year and the next year and the next year. So it's not a matter of waiting for 4 years for everything. There'll be a gradual plan. Thank you.
Member from Dartmouth East, you have a minute and 20 seconds.
A minute and 20 seconds. Well, I think that's what I inherited from the NDP, so should I donate it to back to them? I don't know if you'd like to use that now, but I think it's an appropriate time. We have other issues I'd like to return to another day. I understand that we've allotted, by agreement, some period of 10 hours or so, and so that'll give members. I know there's a lot of local. There's a lot of local issues relative. I know you, Mr. Chair, have always been very much a proponent of in-home support care in your area where it's been challenged across the province by this government. But so I'll just say I'd like to, in closing, thank the Minister for the glossy brochure that is a Band-Aid. The Rumfield direction, she's followed it that well when preparing this. Take every little thing you've done and put it together as a Band-Aid and call it a plan. So I leave you with that tonight. We're not pleased with it. We'd like to see more of a plan. We think you can do better than this. Thank you.
Thank you, Honourable Member. And now recognize the Honourable Member from Halifax Needham. It's 8 o'clock. You have up to 1 hour should you choose to use the full hour.
Thank you very much, Mr. Chair. Thank you. Okay, I would like to go back and talk a bit about seniors again in need of continuing care. And I'd like to talk a bit about the situation in the small, unregulated places where seniors are around the province. And I think this is a really important issue to spend some time looking at, because the public certainly have been concerned about what they saw in the news around how frail elderly people in these homes were dealt with. And certainly there was either a strong perception, if you followed the letters to the editor, a strong perception that seniors were being treated badly. And the minister herself made some fairly strong comments about the approach that had been adopted by the authorities who were involved in transferring and moving people from these situations. And I know that the minister has been to at least one of these homes, the Happy Haven unlicensed facility in Lunenburg County. And, you know, I'm still trying to sort this out myself. Having been here for 5 years, this isn't the first time this issue arose. It certainly was an issue that was on the floor of this legislature when there was a minority government in 1998. And I remember members who are now on that side of the House who took a very firm position in support of the operators of small, unlicensed facilities, and in favor of the family members and who were certainly advocating for some flexibility from government around having a continuum of care that would in fact include these smaller homes. And I know myself, in terms of speaking with some of these operators, that although on the one hand it would appear that the fire marshal made decisions about the moving of people, that certainly the Department of Health were quite intimately involved in this process, in assessing and in advising the fire marshal's office, I suppose, on some level of what was happening and where the department stood with respect to these places. And the minister will know that there are people who work in the field of gerontology and on the care of seniors who have expressed concern about the impact of transferring frail elderly people in these circumstances without the necessary care or planning or some period of adjustment or whatever. So there are a lot of questions, I think, that need to be answered and that have never adequately been answered by government about these small, unregulated places, not the least of which is a question around the standards of care, whether or not the department think it's appropriate to separate couples, for example, frail elderly couples who need care, who continue, who are in situations like this. The whole question of moving people to the extent that they can't see their family members on a regular basis. And I'd like to ask the minister whether or not these small, currently unlicensed places have any place in this government's plan for continuing care. And maybe we'll start with that question. Do these small places have any place in your plan, your government's plan for continuing care? Because there is a real desire, I would suggest, on the part of people in this province for small, personalized, home-like settings rather than large, institutional, very expensive, very costly settings.
I'd like to thank you for the question. I'd like to recognize the Minister of Health.
Thank you, Mr. Chair. And member opposite raises a very important and it's a big issue. It's a big issue that, except for the occasional appearance on the front page, it largely doesn't make the news. In point of fact, we don't actually even know how many of these homes there are in the province because there's no requirement even for registration now, and we don't pay the per diems for the people in them. They're private pay, and they're run by private owners. We do have an idea, but we don't even have a handle on that information, and it is something that we probably should know. Right now, we have a committee of some members from our department and Department of Community Services looking at this issue because these homes have to operate under at least two different acts, the Homes for Special Care Act and then the fire marshal, the issue under fire regulations. And sometimes I know it seems to some of the people involved that the Department of Health uses the fire marshal as a shield to go out and do what it wants because it has an agenda to put everybody into nursing homes. And this isn't the case, but naturally people in the Department of Health and the fire marshal's office are very concerned about safety. One of the issues, though, is in some areas they may come across a home where there are really unsafe conditions. There was a situation like that I've got, a letter about, that the family was really glad the department had gone in and made the people move because the conditions were so bad. She just wished that we'd done it sooner. On the other hand, you have the Happy Havens of the world where they felt that they were providing good care, that they had complied with every request from the fire marshal in the past, and that people were being moved because the department had an agenda. And then you have a slightly bigger facility like Cook Villa, also down there in Lunenburg County, where the pre-Christmas incident took place. And again, those owners felt that they were complying with every rule, but then they didn't know what they were doing wrong, and they still don't know what they're doing wrong. So that's a bit of a long answer to a good question, but they do have a place. But how we're going to, if we're going to move to register these facilities, try to get a better handle on what they can and can't do, because it would seem from the issue of the public interest that we should, because in point of fact, there is a place in the system for homes like this. There's a place for people to go before they need heavy nursing care. And most responsible owners recognize when they can't care for a person any longer. But the complicating factor there is sometimes the hospital sends them right back because they don't have a bed. And another complicating factor is, of course, the families, because we need, as a department, we need our people to be more family-oriented, because there are situations that happen when the family doesn't even know their relative is being reassessed. They don't know of the move. We've left communications to the operators at the home, and sometimes they don't understand what's going on. So all of it gets very, very mixed up. I did go down to Happy Haven after meeting with some of the people involved just to see what the place was like. And I mean, it was one of those places where you go in the kitchen and they feed you peanut butter cookies and squares, and you want to stay there all day drinking tea and chatting. It was very, very friendly. But the real issue there was a certain gentleman who did have Alzheimer's disease but was very physically strong. He was certainly able to get in and out of a place, no problem, if there was a fire. The issue was, would he understand that he had to get out, or would he understand enough not to go back in? And his son and daughter-in-law felt very strongly that he would. And in our assessment, in this particular case, it was borderline, and we got the advice of a non-departmental gerontologist, and Dr. Donaldson was allowed to stay. But his family does recognize that if his care needs to change a lot, that he will have to be moved to a nursing home. But yep, it's another area that needs a lot of work, because we can't say there's no place. There definitely is a place for small, what they consider themselves to be small options homes, in a certain stage of an elderly person's aging process. But that we must make it clearer to families that our interest really is the level of care. It's just that it's hard. I'm sure all members of this House know that it's very hard to think about moving a family member from a home-like atmosphere, if that's what you wanted in the first place, that would be close to your home, into what's seen as an impersonal institution. And at some point, for many people, that step still has to be taken. So to go back to what I was saying at the beginning, yes, there is a place for these homes, but we have a lot of work to do in getting a better handle on how many and what kinds of rules and regulations we should have without being too onerous about the rules and regulations, in order to assure the safety of the people who are staying there. Thank you, Mr. Chair.
Thank the Minister for the answer, and now would like to recognize the member from Halifax Needham.
Thank you very much, and welcome to the chair, Mr. Chair. I want to thank the minister as well for the answer, and I'd like to say that, you know, it seems to me on some level, and I mean Northwood Manor is an example. Northwood is a very large organization. Because it's large, it doesn't mean it's impersonal. And I'm not suggesting the minister was saying that, and I wasn't saying that either. But you'll never have a Northwood Manor in a small rural community, for example. So it seems to me, because the province is so, it's so different from place to place, maybe the smaller places also may have some greater need in rural communities than in the metropolitan area, although I recognize that what Northwood is doing is quite different than what some of these small places are doing. But having said that, my perception is that there's been a bit of a bias in our healthcare system, in our planning for healthcare, perhaps in favor of big operators. And I think that that's something that needs to be addressed if we're going to look at bringing these smaller places under the umbrella of public services on some level. And the minister has indicated that there is a joint committee between the Department of Health and the Department of Community Services, and I'm wondering if she could indicate what the mandate of that committee is, and when the committee will be reporting, when we can look forward to a report from the committee, and where in that process will some of the people who have been affected have a place to participate, because certainly, in the area of continuing care, the larger operators have been very much a part of working with government and planning the single entry system and the need for capital investment in continuing care. And it seems to me that a similar kind of process and the same kinds of courtesies and involvement should apply to this other group as well in this process.
Thank you for the question. I'd like to recognize the Minister of Health.
Thank you, Mr. Chair. Mr. Chair, the committee that we have between Department and Department of Community Services, there are actually two, well, there's probably 10,000 committees, but there's two that are relevant here. One is the group looking at updating the acts under which a lot of these homes operate under the legislation. The other group, which is composed of people from Health, Community Services, and Environment and Labor, which includes the Fire Marshal's Office, are looking at precisely the kinds of protocols and issues that we're dealing with when we look at some of these smaller unregistered or unlicensed facilities, of how we can do a better job communicating with the families, with the operators, with the patients, and with each other, because sometimes we work together and sometimes we don't, and we don't want this perception to persist that the fire marshal's doing one thing and the Department of Health is using the fire marshal as a cover, or they're not working together, or they don't know what they're doing together. We want to improve communication, get more, obviously verbal communication, oral communication, written communication, so that more people are educated about, what we expect and what we can do for them. And then perhaps fewer of these situations would arise in which, and a person has to be moved very, very quickly. That is very disturbing, and it's not just a matter of whether it occurs before Christmas or whether it's a husband and wife. Those things are important. But the whole issue that the member opposite raised about moving elderly people, period, is a huge, huge issue. And even if the move is not unwilling or not, overtly disruptive, it can still cause a deterioration in the patient. I read an article recently about, it was nursing home renovations in a small town in England. And they had absolutely planned their renovations out. They planned where they were going to move the patients to. Everybody knew about it. The family knew about it. And there was, in spite of all that, there was still a deterioration in the quality of the ability of the patient to recover from that kind of a move, because that is the kind of thing that really bothers us more as we get older. Thank you, Mr. Chair.
Thank you, Minister. I'd like to recognize the member from Halifax Needham.
Thank you very much, Mr. Chair. Yes, and I've read a few of the a bit of the literature as well on the impact of moving people in these situations. And one of the things that I've been told is that, you know, the single entry access system, which, you know, we certainly in this caucus support as a form of having a single entry point for assessment for a variety of services that people might need. But one of the things about the actual implementation of single entry here in Nova Scotia has resulted in a substantial increase in the number of times that seniors are being transferred from more than one facility. And as I understand it, there's a reason for this, that people may go into, a senior or a person may go into a hospital. They may be moved from the hospital bed to the transitional unit, to a bed in a transitional unit, while they're waiting for the assessment process to occur. They may go through the assessment process and a bed comes opened in a facility that's not their first choice, and they may be moved to that facility, and then when a bed becomes opened in a facility where they want to be, which is closer to their family, they may be moved again. And I know, for example, of at least one long-term care facility where I'm told that the number of admissions that they are getting now in this facility, 50% of the admissions are transfers. So an elderly person who's been someplace else first. And that this is a significant increase in what they have seen in the past. So I'd like to ask whether or not the department is paying attention to this situation. Are you monitoring this situation? If so, what are you finding? And what's your plan to minimize the numbers of times and the proportion of people who are in that situation?
Thank the member from Halifax Needham for the question, and I'd like to recognize the Minister of Health.
Thank you, Mr. Chair. And I'm not sure if that 50% figure is typical for all homes, but I will check on that. We can get access to that information. I do know that about 40% of the admissions to nursing homes are from hospitals. I would have to go back and do some digging on what percentage of that 40% get moved again, because it is quite true that we would prefer patients to leave hospital if they don't need to be in hospital, but often there isn't a bed available in the home of their choice, so the member opposite is quite right. They'll be moved to a nearby where there's an opening, and then when one comes open where they want to go, they get moved there. I'm sure that we could dig up those figures for the member opposite to find out in what percentage of cases they get moved too often, because obviously the ideal would be to go from the hospital to the nursing home of their choice and then stay there. Thank you, Mr. Chair.
Thank you, Minister. I'd like to recognize the member from Halifax Needham.
Thank you very much. Well, I would very much appreciate knowing more about what information can be provided on that, because certainly one nursing home administrator has expressed to me a concern that the drive for efficiency to make the system more efficient has in some ways left behind some of the care and quality of caregiving that is really necessary in providing care to this group. I want to move away from this particular focus and look again. I had touched briefly in the beginning on some of the barriers to getting access to health care, and I'd like to spend a bit of time looking at this. One of the things, as you know, is the DHAs all around the province have been looking for ways to generate revenue, and they have a little word for it, or a little phrase for it. I can't remember. It's alternative something, which is really code, I guess, healthcare code these days for fees for different things, like fees for blood collection in satellite areas, or fees for parking, and different kinds of fees. Now, one of the things, a recent case, actually, not in my constituency, but in a constituency of one of my colleagues that I've been asked to sort of participate in doing some problem solving around, has been a situation where an elderly couple at different periods of time in the last 6 months have both been hospitalized in the Capital District at the QE. In the first case, it was the male elderly man in the household who was admitted to hospital, and at the time of his admission, there was no ward, I guess you would say, available, and he was placed in a semi-private room. He had insurance, but his health care insurance did not cover a semi-private room. He's been billed for being in a semi-private room, even though one wasn't available. Now, the amount of money is actually quite substantial, especially given that this household, this elderly couple, simply do not have very much income. Now, shortly after he was discharged home, the woman in the household had to be hospitalized. This was before any bill arrived for the semi-private room, so she was completely unaware of the situation. In the I guess the intake process of going into hospital, it was never explained to her. She was asked if she had private insurance. She said yes. She was placed in a semi-private room. They're now dealing with a bill of way more than $1,000, and they have been receiving letters, and in their case, they haven't yet been told that their bill will be sent to, placed with a collection agency. But I've had in my own constituency, members of my constituency who have dealt with the accounts department in the district, with people who tell them that if they don't pay the bills, they'll be placed with a collection agency, that they run the risk of ruining their credit ratings, et cetera, et cetera. So, a fairly aggressive kind of bill collecting going on. So I guess what I'm wondering is, to what extent does the department monitor the practices in the district health authorities for generating alternative sources of revenue, including the credit and collections practices, if you will, of the DHAs? Do you provide guidelines? Are people given any kind of training with respect to what you can, the legal parameters, if you will, within which you can legitimately go out and attempt to collect on a debt? Because I know that, most other credit and collection departments have. They have some legal parameters in which they operate. But so my question is, what do you do about those kinds of situations? Are you aware of them?
And we thank you for the question. I'd like to recognize the Minister of Health.
Well, thank you, Mr. Chair. And I think that we're all aware of the pressure on government and government institutions to raise revenues wherever they can, so that without obviously trying to harm quality of care. And charging for parking, for example, any revenue generation, including charging for parking, would have to be improved by the department in the DHA's business plan. I can recall seeing a few things that certainly weren't approved. But on the issue, and just to stick with the parking for a sec, it's my understanding that if a patient has a reasonable case to be made why he has to be or she has to be in the hospital and cannot afford to pay for parking, I believe that person can apply to the hospital for an exemption in order to get a pass. Certainly, for most people, the nominal charges for parking are not a hardship, but there's always going to be a case where it is a hardship. And there is an out there in terms of being able to ask for a special pass. On the issue of the charging for the semi-private rooms, I'd like to have a look at that case. So if the member would advise me of it, perhaps she already has, and I haven't seen the correspondence. But it certainly does not seem right that a person would be put in a semi-private room because it was the only choice the hospital had, and then that person would be charged for it. It certainly does not seem that should occur if that's in fact what occurred. And perhaps there should be better information given to patients about the fact that they will have to pay, that their insurance won't pay for certain things when it will. And that seems a communications issue, but it does not sound like a particularly good situation. And we'd really like to have a look at that particular case. Obviously, for those who can afford a semi-private room, it's not a problem.
I'd like to thank the Minister. I'd like to recognize a member from Halifax Needham. A member, just to advise you have 30 minutes left in turn.
Thank you very much, Mr. Chair. Thank you. I want to thank the Minister, and I will make sure the Minister does get that information. I believe it's my colleague from Halifax, Shabukto, and I'm not sure if he's written you or not, but I can save him the price of a stamp, and we can get you that information. I want to ask a bit more about the fees, because I guess that we know that user fees exist now in our healthcare system in a number of ways, not just the parking fees, and there are user fees around the ambulance services and certainly children's dental services. So my question is, what is being done to assess the impact of these charges, and what plans might be in place to reduce and even phase them out altogether? Because if they are barriers to health care, this is a problem. And I know that, while it may be true that a patient can ask to have fees waived, some people don't feel comfortable doing that, and because of that, they won't access services. So is there first of all any assessment that's done on what impact these charges have had on people in the province, in various parts of the province?
Thank you. I'd like to recognize the Minister of Health.
Declare revenue. There's no assessment.
Declare what?
Declare there is revenue. No
Oh, yeah.
sales or costs.
But no, there's no plan to assess it. Yeah. Thank you, Mr. Chair. I'm not. We don't have any assessment plans or a system in place now, certainly. But each hospital, each district would be aware of the numbers of complaints, whether they actually have scientific data that demonstrates a consistent barriers to access. That will be interesting information. As I say, yes, some people are not comfortable asking for a special pass, then they may not even have the knowledge to know they should do such a thing. But there really aren't a lot of user fees in the health system. I know that we do have ambulance fees that some people object to, or at the size of them. And we do have small fees for satellite blood collection or clinics in some of the buildings in Halifax. But there are no fees if you want to go to the hospital and have your blood taken. There are no fees. It is still a free service. And really, for the satellite clinics and the ones scattered around Metro, it is a fee for convenience. It is not something that you have to pay. You definitely do not. You can go to the hospital, any hospital, and have your blood taken and have the blood work read by exactly the same people. I don't know why I thought of this, Mr. Chair, and it may not be the appropriate place, but for those who are familiar with the American humorist P.J. O'Rourke, he said, "You think healthcare is expensive now? Just wait till it's free." Thank you, Mr. Chair.
Thank you for your comment. Minister, I'd like to recognize the member from Halifax Needham.
As a strong conservative in the American system, I would understand what he's saying, given that their for-profit system is considerably more expensive than our not-for-profit system, and considering that a lot less people are covered by their system. Anyway, I won't make any comment because it might be judged as being anti-American, and gosh, I wouldn't want to go there. I want to ask some questions then about equipment, and I think the discussion really coming from fee-for-service or fees in our system, and talking about this new investment, $45 million. I think the member from Dartmouth East had indicated. Is a substantial investment. So given that we have a substantial amount of money now to invest in medical equipment, I want to ask you, what is the position of the government with respect to the private MRI? I want to ask why no action has been taken with respect to a private MRI operating in the province. I'd like to know as well when the MRIs at the IWK and in Cape Breton will go into operation. Maybe we'll start there.
Thank you for the question. I'd like to recognize the Minister of Health.
He just said it should be publicly administered or privately delivered.
The Minister of Health.
Thank you, Mr. Chair. This government does believe in a publicly funded system. It is not, and staying that way. I think that's clear from our submission to the Romano Commission. We have made the point again and again, and will continue to have to make to the federal government, as other provinces have, that in order to maintain that publicly funded, accessible system, that we are going to need more and more money. We need the percentage from the feds, and we need the escalator clause. In terms of the private MRI clinic that's operating here in Halifax, we were awaiting a firm position from Mr. Romano, and he did He did discuss the issue of workers' comp clients jumping the queue, and he did address various issues, but didn't come out as strongly as he might have. And frankly, it's a difficult one because the private operators are operating within the Canada Health Act as it exists now. They're not doing anything illegal in terms of the Canada Health Act. And we will be taking a position, but I think the member can appreciate that it is one thing to take a position out of you know, for ideological reasons or whatever, but we aren't that interested in just putting someone out of business or taking an operation that isn't illegal and somehow making it illegal. So the issue will probably be, will this clinic be publicly administered? Because we can have, and that's one of the key aspects of the Canada Health Act, because we have institutions in our system that are private, for example, some food services, laundry services, and so on. They're not direct medical services, but that is, again, different from medical equipment per se. So a service can be privately delivered, but I think that it probably has to be publicly administered. You can learn a lot from the private sector, but in order to be true to, you know, our standards, and she's right, our system doesn't spend as much as the American system. And delivers better service to more people. We will be coming out with a position on that in the next, 6 months? Yeah. Thank you, Mr. Chair.
Thank you for the answer, Minister. I'd like to recognize the member from Halifax, Needham.
Well, this is very interesting. I'd like to explore it a little bit further, although I'm not sure how far I'll get, Mr. Chair. I'd like to know what that means, that it will be publicly administered. Does that mean that the province will buy the operator out and run it, or does it simply mean that patients from the patients will be sent to the private clinic and paid for out of the public purse, and that somehow there will be some kind of a regulatory framework and set of guidelines established to govern the practice of the clinic? Which of those is that, or is there something else I've missed entirely?
Thank you for the question, and direct that to the Minister of Health.
We have an option to require that it be accredited. At the time the clinic set up, we felt we had no legal ability to stop the clinic. So we're looking. Obviously, we're a conservative government. We're not against private business. So we're looking for a way in which this clinic and any other clinics that may want to set up could operate, but still operate within the public administration domain consistent with the Canada Health Act. We do have private operators in the healthcare system. I mean, nursing homes are a good example. We have many private operators, but they still have to operate according to certain rules, and there has to be, considerable amount of accountability to the Department of Health and the government. Thank you, Mr. Chair.
Thank you, Minister. I'd like to recognize the member from Halifax Needham, please.
Thanks very much. Well, I probably recognize as well as anyone that you are a conservative government. What I'd like to know is why on earth would a government of any stripe want, especially in the context of constantly talking about not having enough money to provide the services that people need, why in the world would you then take our scarce financial resources and not apply all of them to the provision of health care? Why would you accept that some portion of those scarce dollars can be used for private profit? That's the question. We don't have a lot of resources. We hear this constantly from government. And in some areas, then certainly you want to preserve as many of those dollars as you possibly can for frontline healthcare delivery, not for siphoning off any of it into areas that are not direct investments in people. And we have $45 million now for diagnostic equipment and other forms of equipment. What possible justification can there be for not putting every cent into our public health care system? I don't get it. Regardless of ideology, it doesn't make any common sense to me.
Thank you. Direct that to the Minister of Health, please.
Thank you, Mr. Chair. And Mr. Chair, that $45 million from the federal government, which we will use in segments of $15 million over 3 years, will all be going to diagnostic equipment and other equipment for hospitals and nursing homes in Nova Scotia. Absolutely. And that includes, MRIs, CAT scanners, lifts in nursing homes, and some of the same things that we spent the previous $15 million on. Now, the list hasn't been finalized, but it will all go to improving services in the public health care system. Whether it's in Sydney or Dartmouth or Kentville or Liverpool or wherever it is. And it won't be going in any way to subsidize a private operation. It will be going to our public institutions. Thank you, Mr.
Thank you, Minister. Recognize the member from Halifax Needham.
Thanks very much. But surely, surely we need, this is a debate we actually really do need in this province. There's a ton of money to be made in our public health care system if we were entrepreneurs. Because, healthcare is something that people are always going to need. It's sort of like food and water and air. And when you think about diagnostic services, then diagnostic services are sort of like they're the core, increasingly. They're an expanding core of healthcare. You have to be able to get that diagnosis. And so it seems to me that once you open up one area of diagnostic services, then you certainly open up the possibility of all diagnostic services. And then once you open that up, then you open it. Surely this is what is the hugest fear of people who believe in a publicly funded and a publicly operated healthcare system is the ultimate beginning of the end of our public healthcare system. And I remind the minister that, your government looked at the P3 schools and did an assessment on whether or not that was a good financial deal for this province, using common sense and forgetting about everything we ever heard from the former government who dreamt up this approach to building schools in the province, and found that money that could be available for education and for schools, money that we really needed, was used for private ends that was unacceptable. And it seems to me that this is the same idea This is unacceptable in our healthcare system where we need this money. We know, we look at budgets let's look at budgets in Nova Scotia. Healthcare every year increases. Our expenditures in healthcare increase, and it's going to continue to increase. Healthcare expenditures will increase because of the increasing cost of technology, the drugs. You know all of the arguments, the aging population, all of these things. So I would argue that I'm not worried about hurting the feelings of one guy who's an entrepreneur who saw a good opportunity. I'm sorry, but there are bigger considerations than some guy's entrepreneurial spirit around setting up a private MRI. Or it's probably more than one guy, actually, several guys. I suspect all guys, but anyway. So I think that, this is this is very problematic, and I think we really do need to have the debate, and I think we need to have it before your government decides to accredit the private MRI and have a press conference in front of a shiny blue backdrop that says this is now part of our health care plan for Nova Scotians.
Thank you. I'd like to recognize the Minister of Health.
Thank you, Mr. Chair. Well, Mr. Chair, I know there are other Conservatives in governments in Canada that have really got on the private healthcare bandwagon, and this province is not one of them. We have not been promoting this in any way. In the case of the clinic that exists now, we just felt we did not have the legislation to stop it. That being said, I agree with the member's point on diagnostic services being very important. That's why we're looking at establishing provincial wait lists. It's why we want to get new equipment as quickly as possible so we can help reduce some of these wait times. And also, before I forget, I would say that there are no public funds going to support this MRI clinic, and we have no plans to do that. Perhaps when we get our equipment up to equipment numbers up to par with some other parts of the country, we will find the atmosphere less attractive for those who want to go into the private diagnostic business or any other business. I know that the member opposite knows this, but one of our concerns, it's obvious, but it should be stated, that improvement in diagnostic services and reduction of wait times is going to have to also be accompanied by reduction in wait times for treatment. Because it's obvious, but sometimes people forget that knowing that you have a certain condition or disease or need a certain operation 6 months sooner is going to be great, but not if you can't get access to the treatment 6 months sooner. Otherwise, it just adds to the anxiety and doesn't do any good. And, we want to make fairly sure through our work with the DHAs that whatever we do to increase access and the timeliness of diagnostic procedures, that the treatments can keep pace with that. Otherwise, we've just gone from one bad situation into, perhaps a worse situation. And that's something that we can't allow to happen. And again, I know that the health critic recognizes this because she's been around this business longer than I have, way longer. But we have to be very aware that some of the wait lists and some of the treatments, that everything improves so fast that you can have everything under control in the health field, like cardiovascular surgery, and all of a sudden, a new method or a new protocol for treating heart disease will come along, and as what happened at the QE2, their waiting list and their working time doubled overnight because they were using more new protocols. And all of a sudden, you had a wait list for procedures that weren't even being done 6 months previously. And so every success has a financial cost. It has a human return, but it has a financial cost. And I know she knows that, but I just wanted to make the point. Thank you, Mr. Chair.
Thank you, Minister. I recognize a member from Halifax Needham.
Yep. Thank you very much, and I want to thank the minister for those points as well. I think that, it is. I mean, I'm not a member of the professional or the medical profession, and I've been here for 5 years and have very little time some days to know what really goes on in the real world, I feel. But reading the account in the Chronicle Herald about what actually occurred was very interesting, because you just see it was well laid out in their editorial, very the detail was there that gave you a sense, and just how fast the medications are changing. It's incredible how fast the drug situation is changing. So it's a challenge. There's no doubt about it. It's a very real challenge. I'm wondering, the minister did make reference to the possibility or, the probability that there'll be an accreditation of some kind around maybe the private MRI. But I'm also wondering about other issues that have certainly been discussed with me about the need to look at protocols. I don't know if protocols are the right word, but some kind of measures that government puts in place to prohibit or to make sure that there isn't conflict of interest occurring between people who work in our public health care system, who are providing and delivering services inside the system, but also investing or participating directly in private healthcare delivery. And I'm wondering if that is an area that the department is looking at, if you've adopted or you're developing any guidelines for members of the healthcare professions, and if so, what can we expect around that whole area of the real possibility of a conflict of interest?
Thank you very much. Would like to recognize the Minister of Health.
Thank you, Mr. Chair. And Mr. Chair, I believe the concerns raised by the member from Halifax Needham are going to be addressed in a position paper that the department is going to be presenting to me, all around the provision of diagnostic services and other issues to do with privately or so-called privately funded healthcare. We are not taking the position that anything other than publicly administered a public health care system is one that we want for Nova Scotia. But there are a number of issues, including that one, a quite important one actually that the member raised, that are going to have to be addressed in this position paper. Thank you, Mr. Chair.
And thank you, Minister. I'd like to recognize the member from Halifax Needham.
Okay, I know I don't have a great deal of time left. I want to ask a question about the number of hospital beds in the province. I believe that during the last 10 years, there's been a substantial reduction in the number of beds per thousand of our population. I believe that the reduction is something like 40%. And I want to know if there's been any assessment of the impact of that reduction, and whether or not such an assessment might be available for public scrutiny to look at, what the impact of the reduction of beds has been since 1992-93.
Thank you. Direct that to the Minister of Health.
Hasn't been assessed then. Not formally assessed, but the political plan does give us the information about
The Minister of Health.
Thank you, Mr. Chair. And Mr. Chair, the reduction in the number of beds, about 2,500 or roughly 40%, the member's correct. We have not done a formal assessment of that, although the rationale for doing it was contained in Phase 1 of the Clinical Services Plan, or the Clinical Services Footprint, as the former minister used to call it. There may come a time for that to be assessed, but right now we believe that even though we're not as ahead as some provinces on home care, that some of the advances in home care and the single entry access for long-term care and so on have mitigated that situation. In other words, a lot of the beds were being used for long-term care purposes, and a lot of people were in hospital. Some might call them social admissions, but were in hospital when they really didn't need to be in hospital. There may come a point where we do an actual paper trail of that, but we don't see any indication right now of that formal assessment being necessary, given the provision of alternative services. Thank you, Mr. Chair.
Thank you, Minister. At this time, I'd like to thank the member from Halifax-Needham from the NDP caucus for her questions, and time has expired this evening in turn. And now I would like to recognize the member from the Liberal caucus, the member from Glace Bay, with 46 minutes in turn. The member from Glace Bay.
Thank you, Mr. Chair. Well, Mr. Chair, I'd like to take this opportunity to perhaps tell the minister a tale which has become a rather familiar tale in this legislature, and it's the tale of the Glace Bay Hospital, Mr. Minister. It's a tale that the former Minister of Health is very familiar with, but has done absolutely nothing about. And it's a tale that, unfortunately, the people of Glace Bay are all too familiar with, and are rather disappointed, to say the least, that this government has failed to address the needs, in particular their needs, the people of Glace Bay and surrounding area, and that of an emergency department in Glace Bay. An emergency department that will remind the minister that was closed at least 32 times last year. An emergency department that, if someone arrived at the emergency department at the Glace Bay Hospital, was just not there. It didn't exist. 32 times last year, and at least, I would say at least half a dozen times so far this year. I may be way off on that figure. It's probably more. But I would suggest, Mr. Chair, I would suggest that under the former Minister of Health, and indeed under this government, that there have been more emergency departments closed in this province than under any previous government before in the history of this province. Now, Mr. Chair, that's not a record that certainly I would be proud of, and I'm sure it's not a record that this Minister of Health is proud of. But nonetheless, it's her problem. It's a problem that she now has on her shoulders, and a problem that I eventually, sometime tonight, would like to hear an answer to, as to what's going to be done to alleviate the problem that exists in Glace Bay. As I said, Mr. Chair, it's a situation now which finds in an area that I've been told by the officials from the Cape Breton Regional Healthcare Complex, there are 30-some thousand visits to the Glace Bay Hospital on a yearly basis, the emergency department of the Glace Bay Hospital on a yearly basis. So based on that, and as John Malcolm, the CEO or the CAO of the Regional Healthcare Complex will tell you, you just can't take those 30-some thousand visits that are made on a yearly basis and say, let's close the emergency department of the Glace Bay Hospital and transfer them to Sydney. Or let's transfer them to New Waterford, which is another story altogether, Mr. Minister, as you all know, because of what's been discussed for the future of the New Waterford Consolidated Hospital and the emergency department emergency department there itself under the Murray report. And I'm sure the minister has made herself familiar with the Murray report and the recommendations contained within that report. Now, these are all situations which, again, and I hate to keep harping on this, but these are all situations that were in the hands of the former Minister of Health. They were all situations that the former Minister of Health knew about and did absolutely nothing about during his tenure as the Minister of Health. This government, during its time in office, has done absolutely nothing about these situations. Now, we're approaching 4 years, as the minister well knows, and we're in the midst of what I think everybody in this province knows now is a campaign that'll soon be launched by this government. But so far, there have been no promises to never close the emergency department at the Glace Bay Hospital again. That's one campaign promise I have not heard this government say. And there's been no money spilling out from the Department of Health saying, here's the money to keep the Glace Bay emergency room and the New Waterford consolidated emergency room open for the next 7 years, which just seems to be a figure that the government likes to use these days, that they'll fund programs over a 4-year period or a 5-year period or a 7-year period, whatever the case may be. Or as the minister of Transportation, I think, at one time said, we'll deal with Sunday shopping in 5 years' time. You know, he remembers making that statement, but it may not be a statement that he'll remember now leading up to election time, because they'll have to eventually make a promise about Sunday shopping. Another story for another day. I'm dealing with emergency rooms right now, and what's being done to treat the people of Glace Bay and surrounding area. Now, at one time, Mr. Minister, you may not be aware of this, but at one time, Mr. Minister, there actually was a plan to put a sign at the bottom of South Street in Glace Bay. The minister may not be familiar with Glace Bay. This is the only street leading to the Glace Bay Hospital, the bottom of South Street. There actually was a plan, maybe the former minister would remember this, by the Cape Breton Regional Healthcare Complex to put a flashing neon sign at the bottom of South Street to tell people whether or not their emergency room was open or closed. Something like the English Town Ferry, you know, is it running or not operating? That was the same kind of plan that they had for the hospital at Glace Bay. Just forward thinking, as far as I'm concerned, for healthcare in this province, to come up with a neon sign that will tell you whether or not you can get the proper acute care that you deserve at an emergency department that is closed. Now, the bottom line is doctor shortage. We know that. There are some that will say scheduling is a problem, local doctors are a problem, but the bottom line we know is that people in that area certainly don't have enough doctors to staff their emergency department. That we know, that the former minister knows, and this government has known for some time now. Now, and I'm going to let the minister answer a general question eventually. I'm not finished yet. I'm going to let the minister answer a general question on what the situation is in Glace Bay and area, in New Waterford and area, and the Cape Breton Regional Healthcare Complex in terms of emergency room staffing and emergency room, just the fact as to whether or not those rooms, departments eventually stay open. But I wanted to remind the minister as well that when you talk about such things as MRIs, and you talk about such things as bone densitometers being added to hospitals, in a lot of cases, Madam Minister, the people of this province are putting that equipment in their hospitals. It's not 100% this government. Correct me if I'm wrong. It's not 100% the funding that comes from this government. It is money that is raised by the community and by the general public that also contributes a major portion of the cost of that equipment going into hospitals. And it's also, in a lot of cases, of new equipment that has been added to hospitals in this province, whether it be in Cumberland County or Richmond County or Cape Breton County. It's also a matter that the federal government has given this province a lot of money to contribute towards new equipment. Now, Mr. Chair, this is money that the province takes, and when they make the big announcement about whatever new piece of equipment is going into a hospital, they don't say, God bless the federal government for giving us this money. They say, we are putting it here as your provincial government. Aren't we great? And in truth, in reality, the federal government has contributed this money, but the province is under no obligation to say that it's federal funds that are being used for this equipment. Now, as I said, the new money that comes from the federal government, or the money that's coming from the community in general, Mr. Chair, and this is from people who go out and raise money in the community. I'll give you an example. There's a house that's for a raffle, I guess you could say, in Bedeck, and they're raising money. They hope to raise, I think, $1 million or whatever the case may be. And probably somebody here, a lot of people here purchased tickets. So on behalf of the regional healthcare complex, thank you very much. It goes towards a good cause. But again, it makes my point that this government is not necessarily coming up with the money for all new equipment, not coming up with the money for health care, but they are taking the credit. They take the credit, and that's all. Now, having said that, Mr. Chair, I would like to just ask this one question, and again, it goes back to well, it's one question for now. I may have to confer with my colleague for more questions, or he may want to take up some of the time remaining to ask some more questions. But, Mr. Chair, just on one question, and again in general, and I hope the minister will reply to the best of her knowledge, and I'm hoping that she'll give me the answer that I'm looking for. But I would like some kind of a commitment from the minister, from this government, that the emergency department at the Glace Bay Hospital will not have to undergo at least 32 closures as it did last year, and that the emergency department at the Glace Bay Hospital will be staffed and will remain open on a daily basis, so that in conjunction with all of the other facilities at the hospital, including the intensive care unit at the Glace Bay Hospital, that emergency room will stay open on a daily basis and provide the proper care for the residents of that area that they deserve.
Thank you, member. And before I recognize the Minister of Health, I would ask the members in the House this evening to quiet their conversation. It's getting rather noisy. So we'll see how that goes before I ask them to take their conversations outside. So we'd like at this time to recognize the Minister of Health, and we certainly enjoy listening to you, Minister, and I'm sure everyone wants to hear you. So please, you have the floor.
I can assure the member from Glace Bay that the intent of the government is to assure exactly what he asked. But he did acknowledge, Mr. Chair, that the problem from time to time is not having enough physicians, and that is something that we know and that we work with the DHA on. It's not a matter of funding, because there's funding for the doctors. There is no plan to have the Glace Bay emergency closed half the time, any of the time. That emergency ward should be open 24 hours a day, 7 days a week. But it is a matter of physician recruitment and turnover, and some of these physicians, as he knows, are staffing more than one emergency ward as part of their duties, and it is a problem that we would all like to resolve, but the intent is to do precisely what a member from Glace Bay says. I would like to just make a note about the equipment funding. I certainly recognize that foundations, hospital foundations, and fundraising events across this province provide a great deal of the money for the equipment going in. We also know perfectly well that the federal government, particularly last year and this year and for the next 2 years, will be providing much-needed funding for equipment in our hospitals. We always acknowledge foundations and the federal government when their monies are involved, and we can't claim the credit for what other people have done. However, one of the issues that is often neglected is the equipment needs to be operated. And the operating funding from the equipment has to come from somewhere. And no, it's not an upfront cost, but it's an ongoing cost, and you always have to build it in to the business plans and operating expenses for the district health authorities and the hospitals. And That is a cost that the province has to pick up and has to plan to pick up. And so we are part of the solution along with the feds and the hospital foundations. Thank you, Mr. Chair.
And thank you, Minister. I'd like to recognize the member from Glace Bay.
Thank you, Mr. Chair. So if I'm hoping that I heard the minister correctly, and I know the minister told me that it's her intent to do everything I say, exactly. If I can paraphrase the minister in what she said her intent is to do exactly what I say. And what I said was keep the Glace Bay Emergency Department open 24 hours a day, 7 days a week. That's what I'm saying. If the minister is committing to that, I'm astounded. I'm openly astounded, and I'm probably finished what I intended to do here. I can go home for the rest of the night, but I can't, and I won't. I won't sit down because I wanted to hear it again, Mr. Chair, is what I want. I want to make sure that the minister is telling me that she is committed here now and her government is committed to not once this year, not once for the rest of this year, will the Glace Bay Emergency Department be closed. I want to hear the minister say that.
Thank you, member. I'd like to recognize the Minister of Health.
Thank you, Mr. Chair. And Mr. Chairman, what I said is our intent is that the Glace Bay Emergency Department would be open 7 days a week, 24 hours a day. That is what the DHA administration wants. That's what we believe to be the right thing. But there are physician issues that make a guarantee of that always being the case impossible, because you need the right number of physicians to make sure that these repeated closures do not happen. And until you get the right number of physicians, no one is in a position to absolutely guarantee that. But that is absolutely the intent. We agree with the intent. We agree with that hospital emergency ward being open 24 hours a day, 7 days a week. Thank you, Mr. Chair.
Thank you, Minister. I'd like to recognize the member from Glace Bay.
Thank you, Mr. Chair. Well, as that clarifies, that's more along the line of what I was thinking. I'm not getting a guarantee. I'm just getting someone who's saying that's the intent. It's everyone's intent to keep it open. It's everyone's wish to keep it open. It's everyone's wish that there were enough doctors there. So let me ask the minister, if that's her intent, then what is she doing? What have been her actions to date to ensure that the Glace Bay Hospital will stay open, the emergency room, 7 days a week, 24 hours a day? And what has she been doing recently to address the doctor shortage in the area?
Thank you, member. I'd like to direct that to the Minister of Health.
I don't know how many we've bought yet. I think we have in the past, but I'd have to find out how many we need to visit. No, I don't know.
The Minister of Health.
Thank you, Mr. Chair. And I'm certain that we can get exact details on ways in which that we have tried to work with the DHA to attract physicians. We do have a physician recruitment program. In general, it is working very well in Nova Scotia, and I'm told that Cape Breton DHA, that people find it very attractive to work there. So I'm not sure what what the problem is right now. I will endeavor to find that out, but I'm sure the member actually knows more about that than I do, given that it's his area. But I will, if necessary, provide the information of how many meetings and what attempts have been made to attract physicians to Glace Bay, because I'm certain I can get that information for him. Thank you, Mr. Chair.
Thank you, Minister. Recognize the member from Glace Bay.
Thank you, Mr. Chair. Well, I was hoping that the minister would know more about the subject than what she's just delivered to me. Certainly could have been brought up to speed from the former health minister, who was trying to deal with it for almost a 4-year period and did absolutely nothing about it. So maybe perhaps the former health minister wouldn't have too much to tell her because of that fact that he didn't do anything about it. But I was hoping that one of the priorities of the health minister, the new health minister in this province, would be to try and solve the doctor shortage in this problem. And as a prime example, for one, Glace Bay stands out. Richmond County is another area that would stand out, and there are other areas in this province who have severe problems with their emergency departments and with doctor shortage. So I'm hoping that a doctor shortage in this province would be one of the priorities that the minister would be tackling right now. and I'm hoping that she knows more about this than she's just let on. So let me give her another chance, Mr. Chair, to say, let's say on a provincial basis, what is being done to try and solve this problem, which has been an acute problem over 4 years. It's not like the government hasn't had time to try and find a solution to the doctor shortage problem in this province. This has been a government that's been sitting there for 4 years. Now, surely somebody has been doing something to try and solve a problem of a doctor shortage in this province. And let me ask the minister what that is they've been doing. And not for an answer that says, well, I'll get back to you at a later date. The minister should be well aware of what's happening with this problem in this province as of right now.
The Minister of Health.
Thank you, Mr. Chair. And Mr. Chair, what I do know is that we're adding, not recruiting, adding 2 doctors a month, 1 doctor every 2 weeks in this province. Now, they are not all in the right place at all times, but we are certainly succeeding with physician recruitment. Our pay is well in line with other provinces. There are people who want to work in Nova Scotia because they like it here and because we have a beautiful province. We are adding doctors. Is the plan perfect, and are they all being added exactly where they're needed all the time? No, of course not. Thank you, Mr. Chair.
Thank you, Minister. Recognize the member from Glace Bay.
Thank you, Mr. Chair. I'm going to turn over soon to my colleague here for the remainder of the time, but just in closing, I know that certainly the plan isn't perfect. No plan is. But what we're dealing here, Madam Minister, what we're dealing with here, Madam Minister, is, as I said, an acute problem which has been there and has been extreme in some cases. It's only a matter of time. May I suggest to you that though all the precautions are taken, that there's an ambulance situated outside the doors of the emergency room at the Glace Bay Hospital when it's closed. It's only a matter of time, Madam Minister, before someone arrives at that hospital and decides for whatever reason not to go through the doors, not to get treated there, to maybe wait out in a car, not go in for treatment because there's no doctor there. It's only a matter of time before someone's life is at stake in this situation. So it is not a matter that I take lightly, and having been in the position of going to that department myself and seeking emergency care, I shudder to think what would have happened if that department had been closed at that time. And I know firsthand what the people at that hospital can do. And I know firsthand how talented they are and how good they are at what they do. So I'm asking the minister, and I'm pleading with the minister on behalf of the people of Glace Bay and surrounding area. As the minister well knows, this is just not Glace Bay. This is the surrounding area. It takes into effect a larger area and a lot more people. But I'm asking the minister to give it a top priority in her department to work with the Cape Breton Regional Healthcare Complex officials, to take the provincial recruitment program and to apply it in all its power it may have to Glace Bay in particular, to solve a problem that has been there for some time and needs to be remedied, Madam Minister. That department, as you said, and I agree with you, needs to remain open on a 7-day, 24-hour-a-day basis. It's the only way that can respectfully treat the people of Glace Bay and surrounding area. And I'm asking the minister to make that one of her top priorities. And with that, Mr. Chair, I'll turn over the remainder of my time to my colleague for Dartmouth East.
Thank you, member, for your time. We'd like to recognize now the member from Dartmouth East with 25 minutes in turn.
Thank you very much, Mr. Chair. And I thank my colleague from Glace Bay for bringing a very important issue. The Cape Breton medical community, healthcare community, has been, I think, a very extremely interesting one in Nova Scotia that to me has been a great success story in so many ways. And the building and coordinating of an area that was fragmented and working against each other, not transferring patients appropriately, all those initiatives and the work that's gone in by many people, both in the administrative and the professional, other professions, and just in the Department of Health, working there. We've seen the growth of the Cancer Care Center, those initiatives. But so when you look at the specialties that are being provided in certain hospitals there now, the new physicians and perhaps the new way of preventative, with emphasis on preventative medicine, wellness. I know smoking, major issue in those communities in that area. So it's been a very positive development, I think, over the last several years in that community. So when you hear things like this, this is disturbing. The people deserve better. They deserve a quality of care that is better than that. There was a time, and I spoke earlier about the high ratio beds per capita, how Nova Scotia led the country by a very wide margin. And if you look at those communities that we're speaking of here tonight were those ones that were extremely high, extremely high. You only had to talk to people who were being admitted and those who had family members that were being admitted, and you see what was happening in that community. It wasn't a good way to practice medicine. I think a lot of things had to change and have changed. I think we can't let it deteriorate, and we have to maintain. Those communities have made great sacrifices. New Waterford and those places particularly have been really concerned about losing their hospital. The role of the hospital have changed. I think the people in that area, they were so taken with their family doctor. Some of them are legends of their time. They would go around 1 o'clock at night. If they saw a light on somebody's bedroom, they'd drop, knock on the door, see if everybody was well. And those are the stories that come out of there. But however, it was a health, a medical model, not a wellness model. So I think the transition has changed, and the people have adapted, I think, within a decade very dramatically in that area. Some of the doctors are still there, 80 years of age, practicing. They were bought off once, and people, they didn't want to tell people that the doc was leaving, so he said the government made him quit his practice. And so anyway, it worked out that he gave his money back from the buyout, that 72-year-old, whatever the time frame was. But that's how attached the people were to their one physician. And now I think they've adapted. The whole healthcare system has changed in that area, and the team approach, and all the various services that have changed in that area. But I think, so they have made sacrifices, and they had a long ways to go, you might say, but it was a cultural change. They had the Chekhov system, very much of a socialist medicine type program there early on, and they had become dependent on a system that had changed and was not adapting to the time. But there are many strengths in the Glace Bay area particularly. There are home care, homemaker services that were the model for Canada, really, and remains in some ways even today. But were the sort of, there was nothing comparable unless you look at something to do maybe with Otis St. Martha's in Antigonish, which would be more of the home care thing. But the points that, the reason that we gave the priority to the issue here today is because we think it's symptomatic of a system that needs support, and they have made dramatic changes, and they deserve better than some of the emergency services that are there. Because someday it's better probably to take the sign down altogether than to have a sign that says emergency department and not have it open, and the unpredictability of it. So I want to thank my colleague for that tonight. I know it's a bit of a ramble, but I think we have to call a spade some days, and it took some dramatic changes. I know I was certainly beat up as a minister on occasion down there. Remember one of the protesters was there waiting for it to get at me for so long, she got tired, so we offered her a bed in the hospital, and she went to sleep and slept the night, and I snuck out and didn't have to enjoy her wrath on the way out. I thought it was one of the, I just share that with you, Minister, when all else fair, there's many uses of hospital beds, and when all else fails and they got you locked in the room, just don't forget that one. There's very few people can avoid just testing a bed to see how it actually works. And for me that night it worked fairly well. But On the long-term care issue, then, moving to that, perhaps would finish some time this evening with this. We look at, Minister, it's 12.20 of the supplemental, and the increase, as was mentioned earlier tonight, 22,952. And the breakdown, I know the day I think it was 8.5 million in the press release today. So that would leave approximately 14 million. And where do you see that being targeted within the long-term care system? We know some of the stresses and strains. In fact, you were kind enough to meet past MLA Don Down and myself and discussing various issues relative to long-term care. But what general area and what can we expect there? We know that there's been some moving of beds around. There's been renovations. There's been building and shifting beds around, but there's been no actual increase in the long-term care beds in this province. And we speak about the Cape Breton area particularly, and you know that it's hurting there. I have with me, or in my briefcase, a letter from a constituent of mine living in Dartmouth East, but has a parent in the Cape Breton area. And some of this correspondence is going back into the year 2002, but she has dementia, she's falling, she's in a residential center, and yet she's told there's no nursing care. Now, these are people who have been very independent and has lived under very difficult circumstances at home, and been now in a home that is just not adequate for care in the opinion of the family. So there's areas like Cape Breton that are, it's well documented that they're in great need of more long-term care beds or facilities. And what is the general 14 million if we're factoring in the 8.5 announced today? Where will the remaining 14 million be designated?
Thank the member for his question. I'd like to recognize the Minister of Health.
Thank you, Mr. Chair. And Mr. Chair, yes, I was made aware soon after assuming this portfolio that the most urgent need for long-term care beds was up in Cape Breton. And we're working with the DHA on that, although the funding that the member refers to does not include money for new facilities. It does include, of course, the $3 million announced in November and the 5.5 towards long-term care funding that we announced the detail of today. There are also salaries in there. We have an increase in benefit funding to the nursing homes in order to help them, and an increase in operating funding. Those are not the benefit funding. That's about almost $1.5 million. We have an increase in pharmacare costs. We have some money set aside for our challenging behavior strategy, or some of the patients in nursing homes need a different kind of care. We are also including some funding for some of the new facilities that have been built, and those incrementally put on top of the other money that the member mentioned pretty well gets us to the 18. Thank you, Mr. Chair.
Thank you, Minister, and I'd like to recognize the member from Dartmouth East.
Thank you, Mr. Chair. Well, certainly the per diems in some of the nursing homes are jumping pretty high, pretty rapidly, and I've been quite surprised by some of them. And I know it's great to see new facilities, perhaps, but some of the increases have been very dramatic, and I'm sure they've come to the attention of the minister. But looking at page or 12.18, the single entry access decreased by 62.7%, or 1.5 million. Now, this was heralded as the great pride and joy and was mentioned every day, came to discussion of long-term care. It was the great savior, the single entry access. Where we learned of it was in our constituencies when people started calling, and what quickly became as a forensic audit of families' resources when application was made for long-term care. Of course, out of this came many problems. Seemed to be some things seemed to go along reasonably well, but other families were dramatically challenged, and so this seemed to be such a great thing that was going to. The answer the previous minister would give to the single entry access, it became a cure-all, and now we're seeing being cut by 60 or 63%. So what challenges will the people experience? What will be what can one expect for these changes? Certainly we know we wouldn't want to see them waiting any longer for the assessment. I think I've shared with the House a bit. One of the calls I had from a person that was it was the member of their family, a sister-in-law actually, that was in intensive care unit in Dartmouth with a mobility disability plus intensive care with, I think, coronary artery disease. And she was had been living with her spouse, her husband, but he was in the hospital as well. And what precipitated the call, he had been deemed to be ready for a nursing home, or at least been medically discharged from the hospital. And he was, I think it had gone from $50 to $100 that day that the person, the family member, had contacted me. So you have two seniors, elderly, both with major medical disabilities, living alone, find themselves both in a hospital. The woman in a wheelchair with a disability, the mobility disability, intensive care unit, husband, her spouse in the other part of the hospital. And those people that with very modest income are being billed 50, and I think it went up to 100. It was either 25 up to 50 or 50, I think, to 100. But 100 sounded a lot, but I think that was the information that I had. And anyway, your staff will know if I'm in the ballpark. But it was a substantive amount of money that was being imposed. So that's the sort of calls that we get to our constituency. And I really find it difficult to explain to people that the healthcare system is better now than it was in 1999. I mean, that to me is a grave deterioration of the whole support system. You can call it community services or health, whatever, and someday they'll all get together. But seems to be a long time coming. But all that type of thing is this the single entry system, and the charging those people, that couple that I mentioned, that kind of under those circumstances, just to me seems to be, it just doesn't make sense. It's not fair, and it doesn't make sense. And we're supposed to compliment you and your government that when their flashy brochure says your health matters. Well, I wouldn't really have taken that glossy brochure down to the Dartmouth General Hospital and showed those people that brought that situation before myself. I haven't heard the outcome recently, but I hope something has come to their senses. So my question would be, what will be the impact if the single entry access system is being funded another way, or under the supplemental details, that it has been cut, and that's what we have to go on, are the estimates. Would the minister comment on the status of the single entry system and what changes one might look forward to, and that might hopefully have a happier ending than the situation that I've just brought before the House this evening from the Dartmouth Hospital?
Thank the member from Dartmouth East for his questions, and would like to direct them to the Minister of Health.
Thank you, Mr. Chair. And in this section, the bottom line shows, estimate to estimate, that the amount being spent is going up, and that's because of additional positions. But the member from Dartmouth East is right. Where it just says single entry access, it looks like it's going down, and that's because some of the costs have been reallocated notionally to different districts, because we're preparing at some point, and all the details aren't finalized yet, that home care and long-term care, when we think we can do it most seamlessly, will be devolved to the districts. So we're accounting for the monies in the way we believe they will be spent, but the total amount being spent on the system is still greater than it was last year, estimate to estimate, because we will be adding positions. Thank you, Mr. Chair.
Thank you, Minister. I'd like to recognize the member from Dartmouth East.
Thank you, Mr. Chair. Okay, so there's, I think I followed that, and whether, I guess that'll become evident in the business plans then of the DHAs when we find the status of those, particularly, I think as long as there's a standard policy, and I think that was the thing that was difficult for people to understand. They had relatives in some parts of the province and were being treated differently. So I think as long as the standard and the is maintained throughout as the evaluation is done for the assessment for placement. On communications, relative to communications, budget 12.3, is an increase there of 26%. On communications. Be interesting to break it down. We talk about, that's an actually dollar increase of 107,000. And the minister could break down that, that amount. And we've seen some glossy brochures, and coming into election campaign, the opposition gets a bit suspicious of the motives of the government, and that government, we have some examples of government, what we deem to be government advertising for political purposes. I think the member who spoke earlier from Glace Bay has brought that concern forward. So the increase is significant, and certainly amounts to a nurse and a nurse practitioner in a rural community for a year more. And yeah, government is about choices, and you have to make choices. So we have the need of those types of services, of, say, to use the example of a nurse and a nurse practitioner in a rural community for a year. Why shouldn't this money, instead of going in communications, is there that much of a need in communications that the government needs help in its message? And can we be assured that this is not a lead up to an election and a feel-good type of communications exercise? So if we do appear cynical, yes, we are. It's a major increase in communications. This government does not have a good record for in using government taxpayers' money to get the political message out. They sometimes even put it on stationery, government stationery. And can the Minister of Health assure the committee here tonight, Mr. Chair, that this is in fact not the case, and can she explain the breakdown of this major increase of 26% in communications to the Department of Health?
Thank you for the question. I'd like to recognize the Minister of Health.
Thank you. Thank you, Mr. Chair. And this particular increase is due to The general 3% increases in wages that you'll see throughout the budgets in various government departments, plus the addition of a communications person who was seconded from education. So in terms of the taxpayer dollar, it is a secondment and it is money that was being paid anyway. Thank you, Mr. Chair.
Thank you, Minister. I'd like to advise the member from Dartmouth East that we have 3 minutes in turn.
So it wasn't a straight trade then, the minister is saying, that because one of the communications people went to education, and how does that work? Does that save you money there? And I don't quite follow that. Is there an extra person in communications and health now?
Thank you for the question. Recognize the Minister of Health with a minute and a half.
Thank you, Mr. Speaker. No, Mr. Speaker, we have another person in communications who came from the Department of Education. But when, I believe the member from Dartmouth East is referring to a person who went from health to education. She went to fill the spot of a person who left government to go to Amira. Thank you, Mr. Chair.
Thank you, Minister. I'd like to recognize the member of Dartmouth East quickly.
Maybe I want to ask that question again. I think we've gone there far enough.
Order, please. Order, please. Order. The member from Dartmouth East has the floor. Order, please.
Just to shift slightly, Mr. Chair, thanks very much for your patience. I'd just like to maybe the last bit, just spend a bit on business planning process and currently and where this stand, the status of the business planning with the district health authorities, and what's the current status of the business planning process?
Thank you. I'd like to recognize the Minister of Health. The Minister of Health.
Thank you, Mr. Chair. And Mr. Chair, the DHAs have their initial numbers, and they will be getting back to us, by the end of the month, if not sooner, on their work through of those numbers. Thank you, Mr. Chair.
Thank you, Minister. Recognize the member of Dartmouth East. 1 minute. 1 minute. It's a long minute and a half, but 1 minute.
I'm being encouraged by my socialist friends to give it my best shot, but I know, having said that, I would totally bomb out.
Ignore the rabbit tracks.
Okay.
But member, maybe you could wait for tomorrow to ask your question. Time has expired for the estimates this evening. And I would like to...
That's my best shot.
Yeah. I would like to recognize the government House Leader.
I move that your committee do now rise and report considerable progress and beg leave to sit again on a future date.
Order, please. Chairman of the Committee of the Whole House reports.
Committee has met and made progress and begs leave to sit again.
The Honourable the Government House Leader.
Mr. Speaker, I move the House will now rise to meet again on the morrow, the hour of 12 noon. The House will sit until 6 p.m. The order of business following the daily routine and question period will be a further review of the estimates. So, Mr. Speaker, I move we now rise.
The motion is that the House do now adjourn and sit tomorrow from 12 noon until 6 p.m. Is it agreed? Agreed.